Okay, so as I was saying before, what you can see here is that for many of these conditions, I apologize. For many of these conditions, we are seeing large percentages of individuals with diabetes that have risk factors that will not only brought diabetes upon them, but still have it that increases their risk of diabetes related complications. This is showing you the percentage of adults that actually meet what's called the ABC goals. And you can see here it says to review the 2019 Standards of Medical Care in Diabetes. I'm going to be taking a look at that for you and placing that as an article for you all to read. But the idea is they're showing you here two goals. And then it talks about the percentage. And the ABC goals for many adults with diabetes is to have their A1C less than 7%, blood pressure less than 140/90, less than 130 for their non-HDL cholesterol, and be a non-smoker. Only about 19.2% of diabetics actually meet those goals. When we look at less stringent goals and see it a little bit higher, they're looking at about 36.4% of diabetics are actually meeting those goals. But in either case, very few are meeting the goals. Obviously, we want them to be at ABC goal level because it would significantly reduce their risk for complications related to diabetes. This is showing you factors associated with prevention, again, of diabetes-related complications. So once an individual is diagnosed, what is the percentage of factors of them engaging in specific prevention factors to control their diabetes better? Only about 34% of diabetics actually have one usual source of diabetic care. And that's one big key area that we focus on, is trying to get individuals to have a source of diabetic care in terms of meeting with their PCP and diabetes education. Only about 16% actually meet 150 minutes per week of leisure time physical activity. 22% are trying to manage or lose weight, and only about 13% are on statin therapy for their cholesterol. So we can clearly see that very few diabetics are currently engaging in prevention, secondary prevention measures once diagnosed with diabetes in order to reduce their risk of diabetes complications. So with that said, we have a lot of work we have to do, not only in working with preventing individuals from getting diabetes, particularly among pre-diabetics, but also working with diabetics to engage in secondary prevention measures that will reduce their risk of diabetes-related complications that usually come from uncontrolled diabetes, and engaging in lifestyle behaviors that further exemplify the diabetes state that they're already in. And so we're going to talk at the end about what we need to do and what is out there currently to work and help in these areas, and what maybe you can do as future healthcare providers, either public health professionals or healthcare providers in your community, to help control the control diabetes and prevent diabetes in these areas. But this is the latest data on how individuals are doing, and overall we're seeing diabetes is increasing, and pre-diabetes is increasing, and individuals are struggling to engage in prevention measures, both pre-diabetic level and diabetic level, to reduce their risk of complications. And we need to engage this and work with these individuals more. So let's take some time now to talk a little bit about pathophysiology and what is the different types of diabetes, what are the complications from diabetes, what are some of the risk factors behind getting diabetes. So there's 4 primary categories of diabetes: type 1, type 2, other specific types, and gestational diabetes. So there are 2 types of type 1 diabetes. There are 2 sort of subgroups. The first one is an immune-mediated. This represents about 5 to 10% of all diabetics. It's an autoimmune disorder that's usually diagnosed in childhood or adolescence. It can occur at any age. Sometimes these symptoms can develop over time slowly. But for most individuals, they're diagnosed and at a younger age, and it develops pretty abruptly, which is why it's considered juvenile onset in most cases. Individuals are what we call insulin dependent when they're type 1 diabetic. Because it's an immune disease, autoimmune disease, the immune cells begin to attack normal functioning cells. This can occur pretty abruptly where it's a very aggressive autoimmune disease. That's when it's diagnosed in childhood or adolescence. But it could be an autoimmune disease that slowly attacks the beta cells, resulting in individuals being diagnosed in their early 20s, because symptoms will develop more slowly over time. But either way, it's a breakdown. The immune system is attacking the functioning of the cells. Idiopathic is really an unknown cause, and these typically occur more in African or Asian descent, and so there might be sort of a genetic component associated with that particular aspect. When we take a look at the autoimmune disease and beta cell destruction, it results in an absolute insulin deficiency. It's an autoimmune disease, literally killing the beta cells. Okay, so it's attacking and eating, if you will, the beta cells. So the beta cells are unable to actually make insulin, and so we're having complete insulin deficiency. We're not seeing insulin here. This leads to hyperglycemia, and it may develop into what we call diabetic ketoacidosis, where we have a development of excess ketone bodies. Ketoacidosis is because when the body goes into a hyperglycemic state, it switches to burning fatty acids, and this produces ketone bodies as a byproduct. Normal individuals have a rate of production equals their rate of utilization. It's in terms of we'll produce insulin to utilize the glucose that has been consumed, and we'll uptake that glucose into our body and utilize it for that energy or store it. But if there is no insulin to uptake that glucose, then there's no energy stored or used, and therefore it starts to burn fatty acids as a way to try to gather energy. Excess ketone bodies can cause most of the symptoms and complications of diabetes. So insulin must be supplied, and this is typically done through regular injections or an insulin pump. Type 2 diabetes, it represents about 90 to 95% of all diabetics. So this is the primary form of diabetes that we see in our country. It was called formerly adult onset or non-insulin dependent diabetes. We'll talk a little bit about why that is. That's because largely it was occurred when people were over 40 years of age. Although there is an increasing frequency in adolescents today, and we believe this is largely due to the childhood obesity epidemic as well. It is a progressive disease, which means it occurs slowly over time. The result is still hypoglycemia, but the issue is it's what we call, there's two common features. It's peripheral tissue insulin resistance and defective insulin secretion. So we're going to take a look at that here. So when we look at insulin action, what happens here is glucose comes into the cell, and when glucose comes into the cell, it is going to signal in the body that insulin is needed, into like sort of the bloodstream as we consume the food. In order for glucose to get into the cell to be utilized, it has to go through what we call GLUT4. This is the transport. So this GLUT4 comes up to the cell surface and forms sort of a transport or a gateway for glucose to enter from the bloodstream into the cell. But the only way that it can do that is through insulin. And so what happens is when we consume food and we break that down into glucose, and glucose is present in the blood, it will cause a signal that tells your pancreas to release beta cells to release insulin. Insulin goes into the bloodstream, attaches to the insulin receptor, which allows your body to uptake this. And this occurs at the level of the muscle tissues, the fat tissues, and your liver. And it's going to take glucose into your cells. Now, the issue here with type 2 diabetes is that we result in what's called insufficiency for type 1 versus type 2 diabetes, we call it insulin resistance. And so what you'll see here with type 2 diabetes is insulin is being produced. The challenge is that the receptors are becoming unable to respond to that insulin resistant. So what happens is the insulin will bind, but there is some sort of defect in the signaling that does not result in GLUT4 coming up to the cell to be opened for glucose to come in. So we have diminished glucose uptake. So you're resulting in more glucose in the cell. So if you go back and remember when we talked about sort of addictive behaviors and how if we overuse a system or if there's an overabundance or need, our body becomes sort of desensitized. And so then what it'll do is it'll produce more to try and help offset that, which in the terms of addiction requires people to actually take in more of that particular drug to get the same response. So that's kind of a similar aspect that's occurring here. What happens is these insulin receptors sort of become desensitized to the insulin resistant. The signal is not effective. So what then does the body do? Well, the beta cells then produce more insulin to get this signal across because it has to get the glucose out of the bloodstream. We don't want glucose there. It will cause complications. So it will do this response, and then basically if you think about it, kind of like we talked about with the heart, if we're overworking the heart at rest, eventually it's going to poop out on us, right? Die on us. It's going to get weaker. That's what happens with your beta cells. And over time, then the beta cells become ineffective. They get overworked, and then they're not able to, they either die off or they're not able to produce as much insulin or regenerate as well. And then we continue to have damage from the glucose, which leads to the diabetic complications. In type 1 diabetes, there's insufficient insulin. They're just not even producing the insulin to have even a response. And you'll see this receptor doesn't have insulin to result in those aspects. And so again, the idea is we have insulin resistance that for type 2 that leads to defective insulin secretion. So over time, pancreas cannot increase it enough to compensate for the resistance, and then you slowly become needing to become dependent on insulin. And this is kind of represented here. This is what with a normal activating system, you'll see plasma blood glucose increase with meals and come back down to sort of normal. It might rise a little bit above that normal level at lunch and a little bit more at dinner, but by the time you fast throughout the night and wake up in the morning, it comes back down to a basal level when you have a normal functioning system. In non-insulin dependent diabetics, their baseline is already higher. So they're starting out at a higher baseline because there's glucose that's left in the bloodstream that cannot be uptaken, and it's just floating in there. When they eat a meal, they spike even higher because their body cannot uptake it. They come back down very similar because the body still is working to some degree, but if you'll notice, it doesn't come back down to baseline really at any point throughout the day, and it takes, not till fasting does it come back down, but either way, they're still starting off at a much higher level of these types of glucose in the cell. So it's insulin resistance that then leads to defective insulin secretion, which then results in higher levels of basal glucose, and this continues to get worse and worse over time, resulting in them eventually needing insulin in order to function appropriately and not have those complications. When we look at type 2 diabetic influencing factors, one of the things that we do see is a genetic influence. Children we see are at higher risk of developing the disease if they have a parent that's type 2 diabetic. So we have a 3.5 times greater than normal, and both parents, they have about 6 times greater than normal. So if their parents have diabetes, then they're at risk for developing diabetes as well. So there is a genetic risk in terms of that. Obesity, as you'll see here, about 80% of those that have diabetes are overweight or obese at disease onset. So we strongly believe that obesity is a one of the primary underlying conditions towards diabetes.